I think. There we go. So yes, we are going to record today's meeting for anyone who isn't able to make it. So, or you just want to reference it moving forward. So we'll be sure to send that out. My name is Nick Medrano. I'm going to be kind of the member from Center, the Coalition for National Trauma Research, guiding this group. You'll be hearing from me. I'll be your point of contact. Today, thank you all for joining this work group orientation. Very excited to start off the social determinants of health work group. You guys are now our 5th work group. So we'll try and use today to get everybody a good understanding of what this project is about. We're kind of jumping in at a midway point here with all these other work groups already running. But you guys are, of course, filling in a very important role looking at this particular group of data elements and making sure that we're going to get these included in this repository. So that's me. Very quickly jump into this presentation. There we go. Just to go over the agenda really quickly. I think it would be good. We have a lot of subject matter experts on this call, kind of from different areas. So if we could do some introductions, everybody get a little bit familiar with who's on the work group, give a brief history over what we've been doing currently with the National Trauma Research Repository, an overview of the current work to incorporate the NTRR, which is the National Trauma Research Repository with FITBR system. And then we'll get a little bit more into what's the work that's going to be done by this work group, and get into the kind of timeline and next steps of what's coming down the road. So I did introduce myself. I will be our kind of main point of contact here at Center, the Coalition for National Trauma Research. So please, here's my information here. I'll also be emailing you. I'll be your main point of contact. You'll be getting emails from me for, setting up the survey, setting up, our next round of meetings, things like that. So please, by all means, reach out if you have any questions about the project as we move forward. And then, Smitty, do you want to lead us off?
Sure, I'd be happy to. Thanks, Nick. I'm Smitty Hebner. I'm a emergency room nurse by background and moved into clinical informatics and regulatory science research. I currently work with the Critical Path Institute, a nonprofit public-private partnership with the Food and Drug Administration.
And then Smitty is going to be our work group leader. He has graciously volunteered to help guide this group. He's also a member of a few of our other work groups, including our CDE steering committee. So thank you, Smitty. Great to have you on the team. So I'll be kind of working with Smitty along a little bit on the side just to make sure this work group's kind of headed in the right direction. Dr. West, do you like to go next? So we can just kind of go down the line here.
Sure. Michaela West, I'm a general trauma and critical care surgeon. I'd actually had NIH-funded laboratory for 20 years, but that's been a long time in the past. I am only working part-time at this point, but I've been at multiple different institutions, and I'm in Minneapolis now at a level 1 trauma center here.
Hi, I'm Christina Colosimo. I'm a trauma surgeon at the University of Arizona, Tucson. I am also the assistant pediatric trauma director and the director of injury prevention and outreach here. My research does I have a lot of research involving gun violence and injury prevention. I actually just got the East Cox-Templeton grant and am currently applying for some NIH funding.
I don't believe Dr. Adams is here. Dr. Lutrick, would you like to go next?
Yeah, sure. Hi, I'm Karen Lutrick. I'm also at the University of Arizona. My academic appointment is actually in family medicine, but I'm a researcher and I do equity research and outcomes research kind of across the disease spectrum from outpatient all the way through ICU. I collaborate with a lot of trauma folks and do, again, a lot of health equity and social determinants of health research. Nice to meet everybody.
I guess I will go next. Tanner from Johns Hopkins. I finished my clinical training at West China Hospital and continue my master's study and postdoc in health sciences informatics here at Johns Hopkins. I'm now a physician scientist by training, and my research these days is mainly about the reliable and shareable patient data. Happy to collaborate. Thanks.
I don't think I see Dr. Green. Dr. Nelson?
Hi, everyone. Lynn Nelson. I'm a professor at the Medical College of Wisconsin. I'm a neuropsychologist by training, and my primary role is to conduct research in traumatic brain injury. I don't have a long history of studying social determinants, but much of my work has focused on factors that predict individual differences in outcome from TBI, and I recently chaired a working group for the NINDS TBI classification initiative, and our working group was focused on psychosocial and environmental modifiers of TBI outcome, along with Monique on this group. So nice to be here.
Garrett, I think you're next up.
Wonderful. So Garrett Hall, I'm a emergency and trauma nurse and also a clinical biomedical informaticist. And I lead initiatives, strategic initiatives at ESO for the hospital market in data collection. My passion is definitely data and data interoperability. And that's why I believe I'm here, because the EDIC group asked for representation to come over to be part of this. So I'm here on behalf of the colleagues of the EDIC committee here at Center. And I'm representing the American Trauma Society on the EDIC committee. So I guess I have dual kind of roles as the ATS, feedback back to them, but also for EDIC. So thank you all for inviting me to be part of this.
Hi, everyone. I'm Juan. Such a pleasure to be part of this group. I'm a physician scientist by training, and I work at the Center for Surgery and Public Health at Brigham and Women's Hospital in Boston. And my research is focused on long-term outcomes after traumatic injuries, trying to understand the causes, and social determinants of health, of course, plays such a critical role into that recovery process. So truly honored to be part of this group and working with all of you.
Hi, everybody. I'm Terry Duran-Cassini. I'm a professor at the Medical College of Wisconsin with Lynn at Froedtert Hospital, which is our level 1 trauma center. I am a post-trauma mental health clinician and researcher. We've had a pretty long history of NIH funding focused on socio-environmental and neurobiological factors that lead to the development of PTSD and depression after injury. We currently have an R01 that's focused on our Black and African American patients in particular, and the socio-environmental factors that influence their trajectory of either recovery or mental health sequelae. We do lots of other research too, DoD funded research on an RCT to do brief modified, what's called prolonged exposure therapy in the hospital, to see who might, the risk for PTSD might go down. And we're looking at how socio-environmental factors, stressors, and structural racism factors influence the effectiveness of that kind of intervention. And then I also direct our Comprehensive Injury Center on campus, which is a newly funded injury control research center by the CDC. And our entire center grant is focused on disparities in injury, vulnerable populations, and those that experience health disparities. And actually, Lynn Nelson leads one of the research projects that was funded by that center grant. Happy to be here.
I'm Heather. Thanks for inviting me. I'm a trauma scientist at the Marshfield Clinic Research Institute in Wisconsin. So it's nice to see a lot of representation from Wisconsin here. My area of research is in social and geographical determinants of rural trauma care. So I do a lot of geospatial mapping and time to care, distance to care, and things like that, clinical decline and acuity on arrival and things like that. So I'm happy to be here.
Great. Thank you all so much for, sharing a little bit about your expertise. I think we have an amazing group of subject matter experts with a good amount of, variety of specialties as well. Olga Vogt is the last member here. She's a data curator with the FITBR system, which I'll talk about in a second. So this project's going to be looking at creating, standardized common data elements for this new repository. And Olga's kind of our subject matter expert in terms of getting those implemented actually within the system itself. So she'll be providing great expertise when it comes to creating and finding elements that already exist or helping us with the creation of new specific definitions for elements. So a little bit of background of just kind of what we've been doing recently with the NTRR and where the project is now. So last year in May, Center received $1.9 million to fund the NTRR, the National Trauma Research Repository. Last year, we were mainly focused on, getting the structure built out of the, Executive Steering Committee, our Common Data Element Steering Committee, and then moving into this year, at the beginning of this year, we have been working with our specific work groups. So in February, we were able to meet actually in person. Our CDE steering committee met in person to look at what we were defining as our core CDEs. I'll talk about those in a second. And then all over since February of this year through pretty much now, we have 4 work groups that have been completing Delphi surveys in order to finalize recommendations for common data elements within the NTRR system. And then just here in August, the NTRR did launch, is currently live. So we've been, socializing its use at many of the different trauma conferences. So I'm sure you have run into, Michelle and Panman and Ashley being out there because it is now live and we're ready to try and get researchers to either be familiar with it and then eventually start submitting their data to it. So an overview of what this project entails, and then we'll get into kind of what your role is with this project. So first of all, the NTRR is going to be seen as somewhat of a sister repository to an already existing repository. So on the left-hand side here is FITBR, which is the Federal Interagency Traumatic Brain Injury Research Informatics System. It already has a ton of TBI-specific data. And the idea is that we're now launching the NTRR, which will be able to house all type of traumatic injury data. And users will be able to pull across those 2 repositories. So because the FITBR system has been around for a while, there is kind of existing infrastructure with it. So we are trying to align as close as we can with that infrastructure. So to make data aggregation on the back end more optimized. So because of that, we're using the same BRICS system, the Biomedical Research Informatics Computing System, which allows and supports research studies kind of from the beginning, whether that's determining what type of data capture forms you're going to be using and the data elements you're going to be using in your study, all the way through submitting that data to the system, and then, of course, being able to pull the data out on the back end. When it comes to the overall approach of what our goal for getting this system up and running is, this top one is bolded because that's where you guys come in. So employing a consensus-driven approach to identify common data elements or CDEs for trauma. We've now been broken up into work groups that are looking at specific areas of trauma. And the idea is as we move forward, we'll have more and more work groups. Other kind of elements of this project are to, of course, clean and harmonize study data in order to get data into the repository, establish processes for the submission of new trauma studies into the NTRR, and then, of course, we want to make sure that there's a process where users can easily pull the data out of the NTRR. A little bit more specifics about what we're going to be doing with CDEs. I'm sure many of you are familiar with the CDEs, but I did want to make sure we're kind of starting with the, the same language. So CDEs are common data elements. These are standardized data elements or variables that are defined and used in the same way across multiple studies. And then that way we can ensure, consistency in data collection. The idea being, if we can get as many researchers to adopt these CDEs in their studies as possible, then when that data gets submitted to the repository, it's much easier to aggregate and analyze on the back end if everyone's using, standard definitions for specific elements, and we're all collecting it the same way. So BRICS, that system tries to use a limited number of CDEs to achieve that consistency. Of course, supporting harmonization across multiple studies. And then we'll get a little bit deeper into using things called form structures. The idea being sometimes it's best not to create specific, really, really specific CDEs, but we can create forms that will actually pull that data better. So we can we may get into the details, a little bit finer details of that as we move into the Delphi process and talk about what our options are for data collection. So the CDE steering committee looked at what we call core CDEs. These were CDEs that we believed could be applicable to all studies and are strongly recommended to be included in a trauma study. And then now what these work groups are particularly working on are what we call basic CDEs. So these are CDEs specific to a specific therapeutic area. So in this case, our group is looking at social determinants of health. In a second here, I'll share what the other work groups are looking at. Because of course, there's going to be some overlap where we have elements that are applicable kind of to different areas. This is kind of an organizational chart of how this project is structured. We have the executive steering committee on top, so everything kind of eventually makes its way to them for approval. The CDE steering committee will be eventually looking at what this group's recommendations are for social determinants of health CDEs. And they also tackled the defining what the core elements were. And then across the bottom, we have the other work groups that have already launched. So we have epidemiology, pre-hospital, acute hospital, and then outcomes and rehabilitation. Now we have social determinants of health, which is launching today. And then we also have other work groups that we believe, of course, trauma is such a large area that there are very specific elements that are going to be, really important, let's say for a burn study, but only be applicable to a burn study. So the idea is that we continue to work with these work groups who can then flesh out what are the most important elements for, those particular areas. So because there have been work groups that have already launched, we already do have some adopted CDEs already that are going to exist in the NTRR system. So I at least wanted to share these with you today. These aren't totally finalized because these groups are still working. They're pretty much at the point where they're going to be writing up their recommendations soon. So I did want to give you, though, an idea of what are the type of elements that these groups have been reporting and recommending, because there's going to be some overlap. I think the idea with this work group is that we get an idea of what are some of the social elements that have been recommended already, because we kind of have, some, but the idea of this group is now expand out and fill all those holes and really make it a robust list of elements that we're collecting. So here are the core CDEs. Once again, these are those that are recommended for all trauma studies. Here on the left-hand side and bolded is just the name of the data element itself. I have the definition in the middle, and then all the potential permissible values, the ways that that question is answered on the right-hand side. So you can see we have things like age, ethnicity, race, a few different gender data elements, person, sex. So we've delved a little bit into these, these types of elements, but we know that there's a lot of room for many, many more. A few other elements that have already been kind of agreed to exist in the system. These have a little bit more to do with the context of how the data was collected. So On the left-hand side is a grouping of elements called the form administration group, mainly dealing with the context of how this data was collected. And then on the right-hand side is what's called the main form structure group, which has to do with just the bare bones information about that particular subject. Visit date, what site were you, the site name, the age of the patient, things like that. So all of the elements here have been adopted, as well as those that I've shown on the first slide, or the previous slide. The reason that I'm sharing these specifically is because there's a couple that are really important from these two forms, one being context type. So here are all the permissible values for context type. So this has a lot to do with the context of the data. So when was this data essentially collected? Is this, very broadly after injury or before injury? Is this, at the time of discharge that we're collecting this data? So, of course, temporality is very important that we, are able to collect that type of information. So here's one element that is, aiming at collecting that very important information. And then we also have another element that's already been approved called data acquisition location. This is, when we're filling out our data collection form with the patient, where are we? What type of environment? Is this in hospice? Is this right at ED arrival? Is this, in rehab? So we understand that both timing and place are very important. So I wanted to make sure that it was clear with the group that, we're of course cognizant of that. We're trying to address that, but by all means, as we work through this process, if you have more recommendations on how we can report that, we definitely want to know. Here's a list of all the elements that have been approved so far by epidemiology. This patient data elements, first table here on the left, is the one that I think is going to have really the most overlap with SDOH. Things like marital status, education level, employment. As you can imagine, they're getting into other elements as well. But the idea is that once these get finalized, I'll be sharing a list of these elements with the group so that the group has an idea of what SDOH elements have already been captured and are already going to be created in the system. I'll be sharing, the element as well as the definition, because sometimes maybe what has been approved by another group, maybe this group's going to have, a little bit more nuance or think that it may be captured in a different way and might provide value in a different way. So we definitely want to get feedback on that. Just because something has been collected in one way doesn't mean that that's the only way that we can collect it. We can definitely have a conversation about how it's being collected. And then, of course, when it comes to, geographic disparities, incident location, of course, is very important as well. So we'll see some overlap there. Pre-hospital work group, these are the elements that have been approved so far and recommended. Not as much overlap, I would say, in terms of SDOH, but we can take a look at these. Mainly, once again, I would say incident, state, zip. So both of these work groups recommended this data be collected. So now we're just ensuring that it's being collected, in a very standardized way. Acute hospital work group, you can see their now list is quite large. Very much interested in initial, right when the patient gets to the hospital type of information. Gets definitely a little bit more into the clinical side of laboratory results, blood products, things like that. But also looks at things like, mortality rates, length of stay, but arrival dates and times, which maybe, is of course extremely valuable. And then outcomes and rehabilitation. This group was broken up a little bit different than the other groups in terms of there being a list of measurement instruments that already exist. And then we have rehabilitation specific elements and then outcome specific elements. So as you can see, quite a lot of work being done currently. These lists are being finalized and written up in white papers to be submitted to CDE and executive committee for approval. But this is a process. So ideally at the end of our process, we will have, a list that looks something like this, where we have, here's our recommendations. This is what we think needs to be collected and how it should be collected. So getting into our specific work group, how is this kind of process going to work? So the first thing starting at the top is conducting a data source review. So how we like to how we've started all of these work groups is by collecting studies, data sources, databases that members of our work group think are important, and collect elements that are very important in your specific therapeutic area. So in this case, for social determinants of health, are there specific studies that have analyzed social determinants of health, or are there databases that you think that we need to pull elements from? The idea being we're going to look at all the elements that are reported in these data sources and get an idea based off of what's frequently reported, what we think the most important elements are, to get us at least at a starting point. Every member of this work group will be able to recommend if you want to recommend a very specific data element, you will absolutely have the ability to do that. Here at the beginning, we just like to start by looking at what are researchers collecting currently to give us an idea of what we think are the most important elements to start with. So that's kind of the first step. Second step being analyzing the frequency of the data elements. So what is most reported in those different data sources, so we can get kind of a tally going of what kind of rises to the top in terms of what might be most important. And then from there, we collect common definitions and permissible values for those elements. So if gender is reported, very frequently, which we know that it is, then how do different organizations or repositories define gender? Because we know that there are different definitions for gender and different permissible values for gender. So the idea is that Center will be then collecting all the possible definitions and permissible values and providing them to this group. And we'll be providing them to this group through a Delphi survey. So it'll be completely online. We will do a short training when it comes to the time to launch the survey. We'll do a short training over it. It's very easy, very user-friendly, shouldn't take you a lot of time to do. And the idea is that you're going to be looking at these elements and you're going to be saying, okay, do I think this element is important enough that we, create it as a common data element? And if it is, then what definition are we going to use for it? What permissible values do we want to have for it? So that will be kind of the main work that we do, is that Delphi process. We'll reach an 80% agreement in the Delphi. It's completely blind. It will be 3 rounds. And it'll pretty much be around for about 3 weeks. And then we at Center will analyze the data, remove elements that reached consensus, and then go into the next round. As I said, we'll do a little training where I can show you screenshots of everything, of how that process works. Very user-friendly. You can leave comments, provide feedback, so that way we can have a discussion about what each other are thinking in terms of why something should or should not be included in the NTRR. And then finally, after that process, we'll kind of circle back after the Delphi is closed, talk through some elements where maybe we need some discussion, and then submit recommendations to the CDE as well as the Executive Steering Committee for SDOH elements that we think need to be included in the NTRR. So that's the overall flow of what we're going to be doing. And then I have it broken up here specifically into what are the work group tasks that you all will kind of be responsible for in one way or another. So the first step is just, what are the data sources that you think that we should be looking at in terms of what are the most important sources for SDOH elements? As I said, of course, you can recommend specific elements, and we can absolutely make sure we include those, pull those, and include those in the Delphi survey. But as a starting point, what are databases, studies that are really important in this particular realm? Once those are kind of sent in to me, then we'll kind of pull those elements, aggregate them, get an idea of what's reported frequently, and then those that are most frequently reported are what will be imported into the Delphi survey. So then using the Delphi process, review the data elements that were collected and arrive at a consensus for what SDOH elements to include in the NTRR. Once we get to that point, then Center will take the charge of kind of writing up the white paper and then provide that back to the group for, comments, recommendations, make sure that everything, looks good and that we are good to submit it kind of up the ladder for approval and eventual creation in the system. So that being said, we have started a very preliminary process of pulling data element sources. So I just wanted to share a couple of sources that we've kind of pulled from so far. And then absolutely, we would like to get some recommendations from this group today, as well as just, over the next week or so, if you could email me, pulling studies or specifically the PI, and I can reach out to them to try and get a list of their, their data dictionary of what elements they collected. But this is kind of what we're starting with at the moment. So these may be some things that are familiar with or new. First being the share CDEs for the NIH minority health and health disparities. So we have pulled those. We have a list of those. Then there's an NIH neighborhood deprivation index. For both of these indexes, both the NIH neighborhood as well as the Health Resources and Services Administration, the area deprivation index, we pretty much just pulled the elements that create that index as a starting point, understanding that they're very broad. And then finally, we have the Agency for Healthcare Research and Quality, AHRQ, Social Determinants of Health database, which is giant. And we've started to at least kind of break it down into specific categories. So you may be familiar with these. Here I have just the NIH share. Here's their CDEs. You can see very SDOH oriented. So of course, economic stability, education, house member size, marital status, things of that nature. The NIH area deprivation index, looking at very similar items, understanding that these deprivation indexes are pulling from typically census data. So it's percent of households without a motor vehicle, things like that, right? We would want to kind of simplify that to a question of, does the specific patient have a motor vehicle? These data points are already collected. So we'll get more into the specifics of this and kind of breaking these down into their simplest forms. So that's the area deprivation index, and then we have the neighborhood deprivation index, very similar items. And then I don't know, for those of you familiar with the AHRQ Social Determinants of Health database, hundreds, if not thousands of elements broken up into kind of different categories, whether that's social, economic, education, physical infrastructure. So these will be broken down into their, once again, the kind of most simple, the simplest data element form that they could be. An example being, one is, percent of the population between the ages of, 15 and 20. Okay, well, that just means we need to make sure that we're collecting age for this patient. So this is the kind of fourth and last one at the moment. And the idea is now that this group will provide either databases or studies that you think have collected important SDOH information. Once we've pulled all those studies together and get an idea of what elements kind of rise to the top to give us an idea of what we might want to include in the NTRR, we will then look at a particular element and determine what definitions exist out there for said element. So I used the example of gender earlier. So if this group wants to, collect gender, for example, then we will begin by looking inside of the FitBur system, since these are sister systems. The idea is if there is an existing common data element that has already been in place and is collecting data and has been collecting data for many years, then we want to try and use that same definition, that same CDE if possible. That being said, if there's a reason why the current existing FitBur definition, has some weakness that we feel that changing it, whether that's the definition or the permissible values, whether we should do that, we can absolutely make that recommendation. And that's kind of where Olga Volk from the FitBur team comes in with the creation of that new element. So that's what we'll start with is, what is the existing definition in FitBur? And then we'll move through these other resources. So whether that's NTDB or TQIP data, other NINS data, NIH NLM repository. And then finally, we have our cancer repository as kind of a last option. So the idea being, if we don't have anything in FitBur, then we're going to follow this order of precedence till we get definitions. And then, of course, if we have multiple definitions, we'll be providing those to you in the Delphi survey. And then the group will determine, what definition do you like and why should we be using that definition with those permissible values. So that's kind of our task. When it comes to the timeline, we will be meeting virtually, I would expect, for the next 5 to 6 months. So we're launching today. The next kind of thing up here over the next month is getting recommendations from you guys on what data sources need to be analyzed, and then sending those to me, and then I'll be pulling them together, and then looking at frequency tables of what elements are most frequently reported to give us a starting point for creation of the Delphi survey. Once we get that list in, that frequency table in, and we can start building out the survey, then we will build the survey. And then the survey should take us about three-ish months. I would say that our goal to kind of launch the survey would be before the end of the year. Then we can launch it and hopefully be done with all of that process by around March. And then that way we can write up our recommendations at around April of next year. So 5 to 6 month timeline, meeting once a month. And then once that Delphi gets sent out, going through those 3 rounds of the Delphi. Dr. Cassini, thank you for joining. Absolutely. If you have to head out, appreciate you joining today.
Yeah, thank you. And yeah, if you could just be in touch, that would be great.
Absolutely. We'll be in touch. So that's our timeline moving forward. As I said, the next steps, I'll be sending out a recording of what I kind of went over today, as well as the slide deck. Establish a standing meeting schedule. So I will be sending out a doodle poll with that as well to get an idea of what kind of works best for everyone. So that'll be going out so we can get a standing meeting once a month. Shouldn't take, it will never be longer than an hour. Some of them, depending on where we are in the process, will be a little shorter. Some will be a little bit longer, but I would say they'll always be between around 30 minutes to an hour. So not a huge time commitment, but we totally understand that you all are extremely busy. But the next thing that, coming from this group specifically would be providing those additional sources. So what are other databases or studies that you think that we should be pulling in order to start building out and getting an idea of what elements are important? So you can, by all means, link things in the chat, or if you want to unmute yourself and share some ideas that you have, we can start brainstorming a little bit. Or if you'd like to take some time over the next, few days and think about what you think would be really valuable, of course, we can do that. I would say that if you have very specific studies in mind, what we really need is a list of the data elements, ideally, a data dictionary, or at a minimum, a data capture form, so that we can get an idea of what the questions were that were asked for that study. We can, of course, look at what came out of the study, the paper itself, but a lot of times there's a lot more elements, of course, that were collected that maybe just didn't make it into, the publication. So if you do have very specific studies in mind, if you could, and you know that PI, if you could also give that PI's information, that would be great, because that way it'll just, or CC them in so that they can just get an idea and know who I am and what we're trying to do. And then that way I can get their data dictionary from them and start comparing their elements to all the others. I know I kind of went through a bit there. Does anybody have any questions, or Smitty, do you have any comments now that you've been through this process before that you'd like to share with the group?
Looks like Dr. Nelson has a question. Let me go first.
I have a lot of questions, so I'll just ask
Yeah.
one for now. I'm
Sure.
thinking to think about the immediate priority here, the data set. It sounds like CDEs are going to be determined mainly based on commonly studied constructs, not which is very different from what are the important social determinants of health in trauma and TBI, right? I think most of what we know in TBI for social determinants actually comes from smaller mixed method studies. The larger studies and things tend to just collect really coarse things, right?
Yeah.
So how should we think about this? What's the framework to think about this?
Nick, do you want to answer that, or should I take a first pass?
You take it first.
Yeah. Yeah. So this group is different than a lot of the others for exactly that reason. And so like there's these two phases. First, we're gonna look to see what's already out there. And then what that does is gives us a place to start on these definitions, especially if it's something that's not already included in one of our preferred repositories. We also have a specific process that Nick mentioned briefly for us to request additional elements that aren't included in any of these other studies or in the databases we have. Then we have to kind of go through a process of refining what is the definition. So there's a little bit of extra work that has to go in there. But this field, especially this social drivers of health, is, in my mind, I'm expecting more of that to happen than has happened in the other work groups. The other benefit is like we get to focus on the social drivers, things about like time from injury, demographic, like the base demographics, your comorbidities. These have been handled by other groups. The treatment, what happens at pre-hospital in the acute care setting, the epidemiological factors, and we get to kind of zero in on, social vulnerability and disease, place-based social drivers of health, other pieces that we really want to see be included in the future. So I think we do have this ability to kind of push beyond what's already been out there. But if we can find what's out there, that gives us a starting point to build on, so we're not building the definitions from scratch.
Okay.
How's that sound, Nick?
Thank you. My second question is, it looked like from your description earlier, like the database will not have to be de-identified. When it comes to like neighborhood level, there's so many, everyone has their pet thing and it's evolving so quickly. Is there a possibility of just putting like census block group into the database so that it could be more flexible?
So I know we've discussed various PHI with others. And so one distinction, we are not creating a full data set that every study has to use. We're creating the options. So I think actual address is in one of the databases already as an element that could be used for that. Is that right, Michelle?
Right. So we were actually just talking about this on our team meeting. We haven't completely dealt with the date dilemma or, other potentially identifying information. And it's on our agenda for our next CDE steering committee, because we've gotten to that point now where we've got some committees that are recommending things that would make it a limited data set instead of a de-identified data set. And we need some guidance from FITBR, what absolutes have they set? And do we, by default have to follow those too? But this has sort of been kicked down the road during this process, to be honest with you. And now it's time to call the question.
I will say, just to add a little bit of specifics when it comes to things like are we going to be able to get zip codes, things like that. I know, for example, in the FITBR system, their particular zip code element only goes for the first 3 digits, which we know for SDOH is pretty useless. Those first 3 don't really give us much. It's the last couple where you can have a huge difference in the social elements and economics of being one zip code over. So that's something that I know currently is as granular as we can get.
I know we also discussed when we first talked about having this meeting, one of the reasons we decided to have a work group was the reality that an area deprivation index theoretically could be an identifier. If you have enough decimal places, it's down to 1 or 2 counties or even 1 census block, and then you're back to a limited data set. So it is something that has to be discussed.
Yeah, for sure. Super important. Another question is, and I'll stop. I'll have other people go. Is this do we have a global lifespan focus? Or it sounds like most or all of us are probably more adult focused. Is that right?
I do pediatrics.
So what's the goal of this working group that way?
Well, thus far, we haven't truly dealt with peds either. So that's another thing actually that we need to revisit with the CDE steering committee. All of the variables, you can be any age, right? But we've not talked about like specific, or even when you look at how education is defined, some of those definitions are obviously for pediatric studies as opposed to, lifespan. So it's a good question and something that we've not completely settled. But this group is going to be very helpful in making us deal with those things.
Sure. And the reason I'm thinking of it is because having just led an NINDS working group for the TBI classification thing, we went into it with these lofty goals. We want to do global recommendations for lifespan for every population affected by brain injury. And we had a tight timeline, and it became very clear very quickly that was just too big of a scope. And although it was disappointing, we had to focus, and we ended up focusing on adults. So again, it's good to like clarify the boundaries, right? Because if we wanted to focus on peds, we would probably need more members.
Yeah.
All right, thanks.
A lot of good content in the chat. And thank you very much for that.
So I just want to add, I do peds research and trauma care as well. And I use de-identified TQIP data to do a lot of like national research. And so they de-identify it by, blanking out the 0 to 1. So that's one way that they de-identify their pediatric data set. Is that your concern, Lynn, or just specific for peds research and trauma care?
Is your question more about my pediatric question or my neighborhood level question?
Well, I thought that you were concerned about pediatric specific for identification, or maybe I misread.
No, I wasn't actually putting those ideas together. Those were for me 2 separate questions of what's our scope as far as age groups of interest, because there's very different literature, at least in TBI, right, on different social factors like family and parent factors that are relevant for kids and not studied in adults and those sorts of things. Yeah, and my question about the neighborhood level markers was, well, more that I think we all know that neighborhood level markers are really important for a lot of outcomes, but there's so many measures and there's the identification issues there. So it sounds like that's something to continue discussing. So thanks. Yeah.
And this kind of feedback is really helpful because it was feedback like this that ended up that told us we need to create another group. We need to do a work group that's on SDOH, right?
Yeah.
And so, that's how it originally, our scope of work was just to do the 4 that you heard about. And that's why we waited to launch this one, because we had that work allotted, during this past summer. And it's a work in progress. For example, we were just awarded a penetrating TBI award from MTech. The prime is University of Chicago, and we're a sub. And part of our work is to do a penetrating brain injury work group, just like this. And so it's very possible that, and you know, now orthotrauma is talking about wanting to use this repository, and whether or not they need this, I don't know, because they've got Metric and some other pretty well established CDEs already. But it could be that we continue on. We've actually been talking with the Department of Defense about follow-on work, potentially being focused on like peds or geriatrics, or, you know, because there's so much work to do. I mean, I think you could probably do 15 of these and still not cover everything the way
Absolutely.
everyone would like.
Yeah, I think it's an amazing initiative and it's a huge undertaking. I think the challenge and the downside of CDEs in general is that everyone starts to think, I have to do this, right? And that's not always the best thing scientifically. And hopefully it's a living document, but I think for these white papers, it's going to be really important to say what context you see these as you know, important in, so that people don't feel like, oh, I have to do this in my pediatric study, even though it makes no sense or
Right.
whatever.
Yeah.
Defining
Right.
the boundaries of it, you
Of
know, for
course.
the audience. Yeah.
And we didn't talk too much about this, but really everything is recommended. And when you're setting up, let's say you decide you want to use this the repository for data collection, and you're picking your, you know, you look at the recommended basic elements for SDOH. You can pick the ones that are appropriate for the study you're doing right now and not use the others. And you can also create unique data elements. There's a process for asking them to add, you know, because you want all of your data to be in that database. So there will be many, many unique data elements as we move forward.
So I hearing all of this, I just wonder if this is something the group may want to consider, because there are so many different domains covered under social determinants of health. Would it potentially, is there areas of expertise where people are experts or know in one domain over the other? For like example, food insecurity versus education versus employment. I don't know, just a recommendation that it might help give some focus if we actually have some domains too that we're going to focus in on as goals to achieve, instead of just leaving it maybe wide open. I don't know. That might help me narrow my focus too.
Appreciate
That's a
that.
great point, Garrett.
Like that.
Yeah.
We will, as we start to identify the most frequently used CDEs, and like you said, Lynn, that doesn't mean that they're all the ones that we should be collecting. We will try to organize them like that. And for the individual subject matter experts on this committee, any question that you don't feel like you have the expertise to answer, you can choose, I choose not to respond. So basically you sort of like select yourself out on that topic.
Any other questions, comments, ideas? As Smitty said, this work group is a little bit different. You know, we have of course are kind of starting it in the same way that we've done with the others, understanding that we believe we're going to get a lot more recommendations, specifically outside of not necessarily tied with this this frequency analysis, and we understand that we have a lot of subject matter experts in these, you know, different specialty areas. So please, we'd much rather start with a larger set and whittle down than not think big enough. But understanding, as you said, Dr. Nelson, that this could just, you know, go and
We
go
could
and
go
go.
on, yeah.
Exactly. Exactly.
Absolutely. I mean, there's a lot
So
of social determinant work in healthcare broadly that
yeah.
is, you know, yeah, TBI is tough because the TBI field has fallen behind in studying social determinants. So, you know, looking more broadly can be helpful, but we don't want to get too broad either. Could you comment on the database that's going to be developed? I know it's using, in a work in partnership with FitBeer, but is it going to function like FitBeer or have any enhancements beyond that?
It's going to be essentially FitBeer. So if you've used FitBeer, the brick system, it's going to be structured the exact same way, when it comes from data capture, submission, reporting, pulling data out, it's the exact same thing. The idea is that once you are in the system, you would pretty much be able to select trauma-specific elements, or do you want to look at specifically the elements that existed already within FitBeer? So the idea is that, you know, FitBeer being just TBI, well, no, I'm not doing TBI. We're looking at these other, you know, much more broad areas of trauma. But no, it'll function the exact same way. Any other questions or comments?
I thought I might just want to circle back to the sort of the age and kind of like life course sort of issue. I think there are a handful, if we're thinking about how this is going to be utilized to sort of use social determinants and see how it's potentially like impacting injury or outcomes, I think that there are probably a good chunk that kind of don't matter, like that are irrelevant of age category, and then there are going to be a handful that are going to be specific for sort of the under 18 and maybe like over 65. But I think as long as you don't get bogged down in sort of that like perfect kind of framework, I think we should be okay. Because again, because neighborhood tends to be such a driving factor, kind of regardless of whether you're 6 or 80, neighborhood matters. And so I think as long as we can kind of keep that anchor maybe, and again, the focus, like kind of the overall focus, right? I don't think this will be used for like sort of a lot of some of the things that maybe some of us that do health equity research do. And so in general, I think it does maybe also have a more limited scope in utility potentially, which might help us not go down some of the social determinants rabbit holes if we keep an eye on that.
Juan, you want to jump in?
Yes, I just wanted to add that I think something that might be helpful for the group is to like define what's going to be the framework. How are we going to go through the different social determinants of health? Because I feel it's an area where there's so many different definitions, so many different ways how you can look at the domains, the constructs, etc. And there's many groups that have tried to define that. I'm particularly familiar, and I would suggest like using the one that AHRQ uses under social determinants of health database. But I'm also aware there are other ways in how to do that. But I think as long as everyone is on the same page and what's the framework we're following, it's going to be key for the future, conversations, and so just that everyone is aligned. I found that one very helpful because it's very comprehensive. I think they draw from about like 40 different types of data sources, including some of this indices that we were just talking about, like the SBI, ADI, etc. So those are already encompassed in that, in that large database. It's a huge database and has a lot of different things, and it's, kind of probably it's going to be hard to kind of digest and like get through all of it. But I think it would be helpful, if we kind of all agree, what's going to be that framework we're going to be following, if it's that one or if it's any other.
That's an incredibly useful sort of database. I think, one of the things that worries me about that one is it is in some ways kind of a composite of all of the other ones. And so and is used in a lot of different arenas that may it might be more useful to sort of start with the stuff that's more relevant to trauma. I live in a world where I sort of also look at like, I'm in family medicine, we do like community stuff where some things are just going to be more relevant if we're following somebody over the course of like 30 years, right? A cancer cohort, there's a lot of those social determinants that really matter for that. But if we're thinking about this and that utility of trauma, I do think we might benefit from really kind of limiting a little bit on utility, because there isn't necessarily going to be the like some of the weathering and some of those kind of like accumulation effects that we might see here in a trauma database or find useful in this outcome. I like that one. It's useful to sort of see how everyone else defines it, but I think social determinants of health is social determinants of health. Like it is very clearly defined by CDC and WHO, and the definitions are really kind of similar. So almost kind of mapping to trauma construct and kind of thinking about what's relevant. And back to what Nick is asking us to do is like thinking about the literature, what does kind of matter here, right? From like a conceptual framework or, you know, from our epi friends that draw the causal pathways and kind of things might be useful.
I'd like to just add one other thing about that. As you were speaking, it reminded me that Captain Travis Polk, he's the leader of this project on the DoD side, and he really kind of set the course. Smitty, you'll probably remember this from the February meeting. He's like, think about, you know, the usual trauma studies. You know, these would be things that would be used for the usual trauma studies. So, you know, 30-day outcomes, maybe 1-year follow-up, like what would be the normal? So you're right. You wouldn't be looking at a cohort at variables that would come up in a large cohort study for 20 years. So that might help frame a little bit the scope as well.
Yeah, I absolutely agree. I think there's that little bit of extra room for aspirational of like thinking about the studies and what are these social drivers that would have been really transformational to add to those big studies. You know, what are the ones that really would have made a big difference in us understanding this disease, these conditions in these patients. Absolutely.
Yeah, and what I was sort of referring to that, you know, large database, I think I know it's huge in scope, and you know, I was, you know, maybe that was you know, come the wrong way, but not suggesting to include, you know, most of those items. But I think as a starting point, and then through the Delphi, we can, you know, define what's relevant. But I feel if we kind of start narrow in focus, we're just gonna go by default, with the elements that have traditionally been studied in trauma. And I think that's, I mean, it's probably just limiting the kind of the survey from the very beginning. And I would like to, you know, have kind of the possibility to think out of the box, see what others in other fields have been able to do using SDOH data, so that maybe we can, you know, we can apply for trauma that, you know, perhaps, you know, we could benefit from it.
We have reached our time for this meeting. I do want to be respectful of everybody's time. I do really appreciate all of the feedback and all of the conversation today. We knew that SDOH was going to be a little bit different, and it's good to start getting this conversation going on how we can kind of frame it and get an idea of how this process is really going to flow. For now, please send me, of course, you can send me data sources, studies, but I also am very interested if we can get a dialogue going about, you know, trying to frame this a little bit more before our next meeting, and then our next meeting, maybe we can come to some more finer details on how big this scope we want to think, and then that way, hopefully by the month after that, then we can kind of get the Delphi going. After we've had a little bit more discussion, because it seems like we're going to need a little bit more than just pulling the frequencies for this group. So that being said, thank you all very, very much for joining today. Please reach out to me if you do have questions. I'm going to be sending out, as I said, the recording, the PowerPoint, trying to get a doodle poll going so we can see when this group can meet next. And by all means, we can continue to give a little bit of discussion in that way as well between now and our next meeting. So thank you all so much, and please reach out if you have any questions at all. Really excited about the work that this group's going to be doing.
Thanks, Nick.
Thanks, everyone.